So I have one foot sort of deeply entrenched in the administrative aspect of medicine, and I have oversight as Director of Medical Affairs for University Hospital, which includes the critical care arenas as well as the respiratory care. We have a very integrated system in critical care that's a multidisciplinary trauma and life support center that has mixed med surg, trauma, transplant, general surgery, medical. We have intensivists from medicine, surgery, and anesthesia. We rotate house officers from medicine, surgery, anesthesia. It would not be unusual to have a anesthesia staff with a senior surgical chief along with an orthopedic intern admitted DKA patient. It would not be unusual to have a medical patient, medical staff from pulmonary critical care follow the surgical patients in the ICU. So it's a very integrative multidisciplinary unit. And University of Wisconsin is a major transplant center, and transplant is a major part of the process. It's a major product line, and it's a major part of what we actually do. And that extends as well into the organ donor management component. So what I was going to do today was show you sort of an overview, a compilation really, of what normally would be 4 to 6 hours of presentations. We do these for the departments of neurology, neurosurgery, anesthesia, medicine, and surgery. This forms the basis of the rotating grand rounds. It similarly forms the basis of the core curriculum for the house staff, both internally as well as these presentations are given externally throughout our region from an OPO perspective and from an organ donor management standpoint. We've done reasonably well with this. Our consent rates historically have been over 90%, conversion rates approaching 90%. So it's an integral part of the process of how critical care curriculums are configured at University Hospital. The program, as it's set forth, is usually divided into the end-of-life components. I think as you recognize that as we unfold into these quality metrics evidenced by the CMS's announcement yesterday that they're not going to pay for complications related to how we track information and data, I think we'll similarly see end-of-life quality indicators unfold along with core regulatory indicators. And I think the reality as time unfolds will see a migration into tracking end of life. So we have 1 hour dedicated to end of life care, particularly focusing on communication that would exist between patients and the actual attending staff physician in the trauma life support center. And I think as that unfolds, as we look at quality indicators, particularly patient satisfaction indicators, that creates an intensive care environment that's very facilitative towards the consent process. We've done that informally. We're now formalizing that. And I think that's part of the reason why our consent rates have historically been so high. This is the university system, and I sort of am embedded down here in the Trauma Life Support Center, which is our multidisciplinary mixed med surg ICU. This now is the pediatric hospital. This is the interdisciplinary research center that's been built. This is the new medical school and pharmacy school. So as you can tell, that's obliterated all of our parking. But because the lake's frozen 6 months a year, it's not a big problem because we can just park right out on the frozen lake. So now the VA hospital, as you can count, is almost 10 stories. And it has an average census today of about 80. So each patient has almost half a wing to themselves. So what I was going to talk to you a bit, and again, I keep this as an open forum. Feel free to interject and ask questions or sort of solicit input, only because I can tell you what I would convey is really anecdotal empiricism and heuristics. There are no evidence-based trials. There's very little information, if any. So what I can do is share with you the 15 to 16 years I've had of specifically managing organ donors at University Hospital, and at least try and convey the sense that we have and the standardized approach that we've undertaken towards that process. So I'd leave it as an open forum. If there are questions, I have no set agenda. I'll walk through as much of this as I can looking at the process. Unfortunately, there is not much organ donor management embedded in any med school curriculum, in our own school included, nursing school curriculum. I directed the Pulmonary Critical Care Fellowship for almost 13 years, and those of you that have been through ACGME interrogations, of which I went through 4 or 5, there's not even a blip on the ACGME radar related to organ donor management. There are virtually no CMEs directed toward this, and there are fundamentally no randomized controlled trials. There's virtually no evidence that's real strong level 1 type evidence to then define a management strategy. And all that is, I think, exceedingly unfortunate, because with the escalating demand for organs and our almost virtual static supply, the maximal utilization and the optimal management of the existing donor pool is the most immediate and practical solution to the organ donor crisis. I say it again parenthetically because I think that's the most important part of any take-home message that I could give to you, is that the immediate and practical solution really is the maximal utilization and the optimal management of the existing donor pool that's in your ICU, that's in our ICU. It really is one unique opportunity that we have to simultaneously medically manage 6 to 8 other lives at once. And that's really the conceptual framework of operationalizing donor care management, is to conceptualize to the caregivers, whether they're traumatologists, medical intensivists, neurointensivists, is that this is a unique opportunity, realizing that the donor is dead, to have some good come from the tragedy, that this is really the fundamental medical management of 6 to 8 other lives at once. And with the increasing recognition of an immunologic continuum between the donors and the recipients, the intensity of the inflammatory response in the donor probably dwarfs what we see in sepsis. This creates the framework of inflammation that's thought to lead to the immunogenicity that's prevalent in the delayed graft function and the longitudinal abnormalities in transplant grafts. The consequence of which is that the goal in management is to mitigate against ongoing ischemia-reperfusion injury. And that's really thought to be the bigger culprit that jeopardizes organ function. That really is predicated upon solid intensive care management that's indistinguishable from the management that you would have for any other patient in intensive care. And it is the simultaneous medical management of 6 to 8 other lives. And all these look like little stick figures that have a great deal of anonymity. There really is no anonymity here. These are real people. These are real people waiting time on the transplant list. And I think any of you who've taken care of kidney patients who are in renal failure, maintained on dialysis, the change in their lifestyle, the quality of their life, the incremental amount of things they can do when they get deburdened from dialysis with a kidney transplant is enormous. From a societal perspective, it's unambiguously, clearly more cost effective to have a patient transplanted than it would be to have ongoing dialysis. 10 to 15% of the patients who are on the heart-lung list will actually die on the heart-lung list. There is enormous opportunity in the critical care arena to then establish more functionality in the organs and then stabilize the donor so those organs can actually be procured. I framed the discussion around the background of the supply-to-demand relationship, highlighting lung donors. And the actual supply has, by and large, remained virtually static. One might argue that the collaborative and HRSA have increased this to a degree, but the supply is virtually static. The demand continues to accelerate. There are currently over 100,000 patients on the transplant waiting list today. And I'd highlight lungs because, from a societal perspective, we have probably the most egregious job have done the most egregious job in procuring lungs. 15 to 17% of actual donors have lungs procured, recognizing that the conversion rate, which is the number of potentials converted to actuals, is only about 50% or so. That means that only 8% of potential organ donors have lungs procured. So from a lung perspective, there's enormous opportunity to really enhance the management skills of the intensive care environment, to work with the OPO to facilitate greater procurement in that arena. If one were to look at the largest 300 hospitals in the country, there's enormous variability between some hospitals that convert 20 to 30% of their potential donors to actual donors. Others convert 80 to 90% of potential organ donors. Enormous variability amongst the largest hospitals in the country. I guess as a PG-26 as of July, I'm old enough to remember Standard Oil. Any other PG-6 type, PG-26 type people over 50 remember that? Well, Standard became Esso, which became Exxon. And it actually originated, why they called it Standard Oil had to do with the fact oil was discovered in western Pennsylvania in the late 1860s, 70s. Cleveland was the oil capital of the country at that point in time. And J.D. Rockefeller produced a horrible product. It was not consistent. The kerosene distillation process was colossally ineffective, inefficient. It didn't sell. So he brought over a fellow, an Englishman who was a chemist named Andrews. And Andrews later became a managing partner in the entire conglomerate and operation. But he was a chemist who really standardized the distillation process. And it worked. And it sold. And they were so enamored with the process of standardization that they named their oil company Standard Oil. So whether it's the GE Six Sigma, the Toyota product line, or what we're being hoisted upon by IHI It's standardization. It's mitigating the variability, consistently doing the right thing, standardizing process that ultimately facilitates outcome, whether it's distilling oil or taking care of patients. Granted, there is variability embedded within patients, and that goes without saying, but it's consistency of process and migrating through a standardized process really that facilitates better outcomes. The key things embedded in organ donor management that are standard, both from an experiential model as well as from a literature model, would be surveillance to define those patients who are highly likely to proceed to brain death, an unambiguous, unequivocal understanding of the physiology of brain death and a standardized methodology for its declaration, an unequivocal request for consent at every instance, and the optimal medical management of the donor. The optimal medical management of the donor is actually of pivotal importance because, one, the donor has to survive somatically so procurement can be undertaken. It really requires a focus shift away from cerebral protective strategies to optimizing end organ function in those patients who would be the recipient. With the increasingly recognized immunologic continuum between the donor and the recipient, how we manage the donor in the intensive care unit, again, not only impacts upon the procurement, but it similarly impacts upon the quality of the organ and the quality of life of the recipient. So there is an enormous emphasis in our ICU with the donor management team to really assume the management of this population and to treat this population as an indistinguishable patient from any other patient in the ICU. We'll skip surveillance other than to say there's a lot of literature on how you survey these patients. The reality is in most large ICUs, roughly 6% of all deaths are brain death. So we will admit 2,600 patients per year into our ICU. We have an SMR of about 0.68 with an absolute mortality, probably somewhere around 220, 230 patients a year. If you multiply the numbers out, we'll have about 22 to 24 deaths per year from brain death in our intensive care unit. I'm sure it's not a whole lot different. Other ICUs that have different orientations, maybe a little more, a little less, but roughly 6% of an admitted population who dies will die of brain death. That's not to account for the 95+% of patients who die with care being withdrawn or withheld in critical care today. The idea of somebody dying with their foot on the gas going 100 miles an hour with a full resuscitation almost doesn't happen. Many times with ECMO and things like that, sometimes it's hard to figure out who's alive and who's not alive. But the reality is the withdrawal of life support dominates the end of life for many patients in ICU, but about 6% actually have physiologic brain death. And the original description of brain death was by Harvey Cushing in 1901. This is his original manuscript. And this is the lab animal that Harvey Cushing used. So the bonus question is, what animal did Harvey Cushing use in his lab research? I don't know. There's rumored to be a neurosurgeon neurosurgical resin who was only working 140 hours a week, and he got sent to the lab for a year, was never seen again. But it was actually baboons. What Cushing described was Cushing's response, which is a compensatory increase in catecholamines to maintain cerebral perfusion pressure gradients. After the initial activation of the vagus nerve, precipitating bradycardia, what he described was ischemia at the virtual medullary level that generates this intense catecholamine surge to maintain the gradient. So with Poiseuille's law being applied with incremental pressure at the downstream, you have to have a higher perfusion pressure gradient to maintain flow. And this is a compensatory response. What he did actually miss initially was the vagal activation. So the first sign of increased intracranial pressure with incipient herniation really is bradycardia, hypotension, and low flow. With ischemia at the pons level, consequent to this rostral caudal progression of ischemia, this is what Cushing actually described. With ischemia at the medullary junction, this is really sympathetic surges, catecholamine levels 2,000 to 3,000-fold normal to maintain perfusion pressure gradients. This is an enormous stress to the myocardium, jeopardizes left ventricular function significantly, but in animal models probably shown to jeopardize right ventricular function even more than left ventricular function. Coincident with this catecholamine surge and the ischemia at this area is hypothalamic pituitary destruction, thought to relate to the ischemic events and pituitary destruction that is thought to be the provocation for the endocrinopathy of brain death. Very speculative, very uncertain. You could cut my head off today and my thyroid binding at the periphery would probably be the same for a week. Many patients who take thyroid don't take it for a week, and there's no major losses there. So it's a very speculative phenomena, probably more related to the intensity of the inflammatory response and a almost virtual euthyroid sick, or the relative adrenal process that's thought to occur consequent to inflammation. But for whatever reason, this has now become embedded in the culture of organ donor management, and there is a fair amount of animal data, some human retrospective data that suggests using hormonal cocktails actually facilitates recrudescence of organ function. Hypothalamic destruction leaves a poikothermic patient who has thermoregulatory impairment, and when the ischemia reaches the spinal cord, there's sympathetic deactivation and a deinnervated patient. So oftentimes it's the triple whammy of hemodynamic instability. It's intravascular volume depletion in an attempt to then mitigate against cranial pressure and swelling, profound cardiac abnormalities consequent to the catecholamine surge and the antecedent pre-neurocardiac axis damage that occurs with severe brain injury and vasodilatation. So it's a very complex population to manage and to manage well. This is a serendipitously gotten MRI of a fellow who herniated in the midst of his MRI. Presented with nausea, vomiting, seen on neurology service. CT was normal, sent over to MRI. He herniated and died in the MRI scanner, brain death. So you can see the comparative MRI images of the magnitude of the compression at the brainstem level. So this is brain death in evolution. The pathophysiology of the graft is really thought to be related to ischemia reperfusion injury. And this occurs at multiple junctures related to the initial resuscitation, the catecholamine brain death storm, which has such an intense level of vasoconstriction that it jeopardizes organ flow to maintain flow to the brain, followed by vasodilatation, reperfusion, and then multiple instances of storage and retransplantation. I think all of you know these are the sequelae, the physiologic phenomena related to ischemia reperfusion. This is thought to occur possibly against the background of an endocrinopathy, dominated really by thyroid and cortisol abnormalities. Thyroid has dominated that literature, and it's very, very, very convincing in animal models, particularly if thyroid hormone is thought to maintain the mitochondria, which then allows for energy uptake, ATP production. Loss of thyroid hormone jeopardizes that ability and then mediates a transition from aerobic metabolism to anaerobic metabolism. Multiple animal studies have shown giving whopping doses of thyroid hormone almost recrudesce the hormonal milieu and actually revamp metabolism from a anaerobic metabolism into aerobic. Yet there are multiple studies that can't even define the presence or absence of an endocrinopathy. There are multiple studies that show no correlation between lactate levels, organ dysfunction, and the level of the hormonal concoctions or the hormonal levels. So it is a very speculative thing, but it's now become entrenched in a lot of the management protocols simply based on the very appealing notion that if you've lost your hypothalamic and pituitary axis, you must be relatively hypothyroid. The ischemia reperfusion injury is thought to activate donor cells. The intensity of the inflammatory response is significant. This produces a local inflammatory response, which is thought to then engender graft immunogenicity, which is amplified by reperfusion and is thought to form some bases, not all, but some part of acute and delayed graft dysfunction, as well as longitudinal elements of dysfunction. Again, grafts that don't do well initially tend not to do well longitudinally. This is probably, I think, best exemplified in the renal transplant literature where non-HLA matched living donors, almost uniformly do worse than HLA matched cadaveric donors. Almost uniformly do worse. And it suggests that brain death is not really static and the graft's not biologically inert, but this intense inflammatory response in the donor engenders an immunogenicity in the recipient, in that organ when it's transplanted. And the graft is actually inflamed and primed to be activated and participate in this host alloresponsiveness that would be delayed graft function. So the idea is to mitigate against the inflammatory response on an ongoing basis in the donor. In the future, the strategies won't be necessarily targeted at using the UW solution to then preserve what's already damaged. We'll move more and more into attenuation strategies, which is what our labs are looking at now in terms of IL-1 blockers and other things, much like sepsis, things like activated protein C, other things that blunt the inflammatory response and precipitate and mitigate against the inflammation in the donor rather than storing an organ that's already damaged. The intersection of transplantation and brain death really occurred in 1967. This is the cover of Newsweek when Christian Barnard transplanted the heart of brain-dead 19-year-old, actually, I thought you said 19-year-old Ann Duverall into a 56-year-old cardiomyopathy patient. Probably the second time that had ever been done. One case in Belgium probably before this, but this was the case that really achieved the notoriety, that really jettisoned the discussion of what constituted brain death. Remember, Mulleret published his landmark paper in 1959. Heretofore, brain death had never actually really been described. 1967, this was an exceedingly controversial process, exceedingly controversial. And I'd read to you the accompanying editorial that says, when in fact is a person dead enough to be deprived of vital organs needed to maintain the life of another human being. So this is not ancient history. This is actually relatively new. This is 1967. Consequence of this, well, actually the lead we got from this was from our colleagues in the American Legal College, who said you're dead when your doctor says you are, and death comes when a physician has done everything to save the patient's life and comes to a point where he feels the patient can't live. Well, that sort of rather patronizing view of defining life and death for patients probably wasn't applicable then and certainly wouldn't be applicable today. Consequent to this, Beecher convened a group at Harvard, the Ad Hoc Committee to Define Brain Death, that was done in 1968. It wasn't until 1983 that the President's Commission actually equated cardiac and brain death. So this is just after I graduated from medical school. So when I was a medical student, the idea of brain death was a very uncertain process. It was only in 83 that it actually became codified and equated to cardiac death. The committee was made up of members from the School of Law, Medicine, Divinity, Public Health, and they put together the criteria that eventually were used, embellished a bit, and constituted what the President's Commission suggested. So we're fairly simple in the Midwest. We watch a lot of TV, don't get out much, winters are cold, and we depend upon the West Coast to kind of guide us. And probably one of the best delineations of certifying brain death comes from The Wizard of Oz. And it's got to be morally, ethically, spiritually, physically, positively, absolutely, undeniably, reliably dead. Not merely dead, but seriously dead. And I say this not to be flippant, I say this not to be facetious, because there's nothing in medicine that anybody should be more sure of than declaring somebody dead. There's absolutely nothing that dissuades the family's confidence, that dismays the family as having a patient being pronounced dead, then being pronounced undead, and then being pronounced dead again. It is the absolute prerequisite for organ donation to proceed. It is the absolute prerequisite, really, for the discussions to occur with families. And it's an absolute critical part of intensive care. Probably 85 to 90% of our deaths are done on physical exam. We use Widgett's position paper. We march through the exclusions, preconditions, look for the reason for death, and it's always self-evident. March through the cranial nerves, do apnea tests, and the vast overwhelming majority of deaths in our unit are done via physical exam. And that's how we do it. And it's done by the intensive care service, by the neurology, or more likely neurosurgical service who does this. So it's an integral part of the process of training. In the core curriculum that we have an hour of end of life. We have one separate hour that I teach to neurosurgery, neurology, anesthesia, medicine, surgery on the diagnosis of brain death. Then we have cardiac and pulmonary management. So this is a 1-hour lecture specifically on the history, the physiology, and actual declaration process for brain death. There's extraordinary variability in the country in how this is done, what the requirements are. In reality, it's a very simplistic, straightforward process that requires exclusions be taken out of the picture, preconditions be satisfied, a reason for the coma, cranial nerve dysfunction, apnea test. If any of the physical exam findings cannot be undertaken, it warrants a complementary test or a confirmatory test. And that's the model that we've used, and the vast majority are done via physical exam. Talking very briefly about consent, I think one might argue that the capacity to facilitate optimal consent is really predicated upon the stature and the processes involved in end of life in care in that ICU. recognizing clearly that there are basic sociodemographic characteristics for patient substrate, i.e. there's multiple data points that suggest certain ethnic groups, certain circumstances, donor cards facilitate that. But the reality is part of the capacity to ensure that there's a quality care in the ICU, and particularly a quality end-of-life care and patient family satisfaction, facilitates the actual transition in care. In our system, we do separate these, the diagnosis of brain death and the request for consent unless asked by the family, but we spend an enormous amount of time on quality metrics, quality items for end of care and end of life. And if one looks at the Robert Wood Johnson multiple position papers, and particularly the evolution of quality indicators, I don't think there's any question that these will be embedded in reporting structures in the very near future related to intensive care. So there are about 18 quality metrics now that can be looked at. And as one proceeds with quality of end-of-life care, and again, recognizing that probably 95% of the patients who die in the ICU have care withdrawn, and 1 in 5 Americans will die in an ICU. This really is an integral part of intensive care medicine. We formed a working group of about 20 people, broad representation from medicine, surgery, nursing, department directors and family services, bereavement, palliative care, and put together our own sort of end-of-life process that focuses on care of the patient, family, ensuring donation is built into end-of-life, as is autopsy. My own personal autopsy consent rate's about 85%. Because every single case has a request for autopsy made. The autopsy is done by the team that took care of the patient with me, reported to the family that day. Call goes out to the family, letter in 2 days, formal letter with neuropath in 6 weeks. About 15 to 20% of the families actually come back and review the autopsy item by item. So again, it underscores that having a consistent, integrated process for end of life is actually imperative to ensure donation is built into the process. Equally as important, I think, to admitting patients is how we discharge them. Well, all the criteria that we're up against now in terms of mandated reporting for handoffs, handing somebody off terminally is equally as important. So we dedicated a substantial amount of time and effort. It's faculty driven at the bedside. The critical care service actually handles all the DCD cases, and when lethality has been defined or futility has been defined or brain death, those cases are actually transferred to the critical care service. Medical management is the last step, and I'd underscore that this really is a collaborative, multidisciplinary effort. I think it's inherently no different than any other patient. It's the medical management of 6 to 8 other lives at once, simultaneously. And in reality, if we had a 21-year-old college student that came in with meningococcal meningitis, who had DIC, cardiac dysfunction, needed dialysis, the rapidity with which we would move in securing access for dialysis, getting a cardiac echo, transfusing appropriate products would be staggering. In reality, with a donor, we're managing 6 to 8 other lives at once. So it's the same level of focus, the same level of intensity, the same collaborative relationships that should exist in multidisciplinary critical care units. This is the paradigm that we use for DCD when the primary service, whether it be trauma, neurosurgery, or neurology, has actually discussed the case, and again, this comes after the delineation of futility. This is the non-brain dead population. That discussion occurs staff to staff. The critical care service then assumes management and the palliative care aspects of that and undertakes a withdrawal of care. Again, this is a separated discussion. There is an initial delineation of futility, that the family is unambiguously on board, that they've all reached a unanimity and consensus that this would not be anything that the patient would want. Care is to be withdrawn. The OPO meets with the family. If there's consent for donation, then the critical care service assumes management. In other instances where lethality, the gunshot wound to the head, or if a patient has been declared brain dead, the donor management team is activated as a PG 26 now. I guess I've been able to delegate some of this, so we have the critical care service triage attending, although I'm always the backup for that, and these patients are managed in conjunction with the OPO. The focus oftentimes, as it should be, is on cardiopulmonary management because, one, the donor has to survive, and optimizing organ function for the other kidney, liver, pancreas really is predicated upon solid hemodynamic management. And I think what I'd underscore is that we oftentimes inherit a patient who already has significant neurocardiac axis abnormalities. clear data from subarachnoid hemorrhage in patients who survived show significant cardiac impairment. So obviously the tier of patients who've succumbed to their illness are probably at a much higher level of neurocardiac injury. Against that background, prior to brain death, there's the brain death event itself.